My name is Betsy Robbie, and I'm a registered nurse and certified diabetes educator. I work for New West Physicians in their Diabetes and Nutrition Department. I'm here today to talk to you a little bit about how to get your program accredited through the ADA or the AADE for diabetes self-management and education. We were already doing most of the measures for accreditation and wanted to get credit for our program. We wanted to be able to measure and maintain the quality of our program. So last May, I put my efforts in and we got our program accredited. So I'm going to tell you a little bit about how to do it for your diabetes self-management education program. First, let's talk a little bit about what diabetes is. We know that diabetes is a chronic disease that requires a person with diabetes to make a multitude of daily self-management decisions and to perform complex care activities. Uncontrolled diabetes causes damage to the small and large vessels and organs and nerves. According to the Colorado Department of Health and Environment, nearly 300,000 Colorado adults are estimated to have diagnosed diabetes, and another 110,000 could be underdiagnosed but living with the disease. The prevalence of diagnosed diabetes increased 55% from 2003 to 2014. 91% of these adults had at least one other chronic health condition, and 68% of non-traumatic lower extremity amputations occur in individuals with diagnosed diabetes. Providers can serve an important role in educating patients on best practices for disease management and lifestyle changes proven to prevent or delay the onset of complications. In 2012, among adult Coloradans with type 2 diabetes, only 56% checked their blood glucose daily, 84% had their A1C checked in the past year, 64% had their A1C checked more than once, 83% had a medical visit for diabetes in the past year, 67% had an eye exam in the past year, and 73% had a foot exam by a healthcare provider in the past year. Let's run through some of the consequences of poor glycemic control. In 2011, diabetes was listed as the primary cause in 44% of all new cases of kidney failure in the U.S. And in that same year, almost 229,000 individuals suffering from diabetes-related kidney failure were reported as living on dialysis or with a kidney transplant. Similarly, in 2010, U.S. doctors performed 73,000 non-traumatic lower limb amputations on adults diagnosed with diabetes. Diabetic patients are at an increased risk of having surgical site infections for the majority of surgeries. Surgical site infections are the most frequent cause of hospital-acquired infections. Annual healthcare cost of surgical site infections is more than $3 billion. CMS can penalize hospitals for readmission within 30 days. The Diabetes Self-Management Education Program is an evidence-based model to improve health outcomes for people with diabetes. Diabetes self-management education and training provides the foundation to help people with diabetes to navigate the required daily self-care decisions and activities, and has been shown to improve health outcomes by reducing A1C, reducing hospitalizations, reducing ER visits, and improving wound healing. Diabetes self-management education is covered by Medicare, Medicaid, and some private insurance companies. Patients with private insurance should be encouraged to know their benefits of their individual plan. This slide talks about the program overview of what diabetes self-management education, the details of it. So provider programs can be accredited through either the American Diabetes Association or the American Association of Diabetes Educators. The benefit provides up to 10 hours for the first 12 consecutive months after the first diabetes self-management visit. Training can be performed in any combination of 30-minute increments. The exception is for federally qualified healthcare centers. Medicare will only reimburse for diabetes self-management education provided as a one-on-one. More of the 10 initial diabetes self-management education hours can be provided as one-on-one, with the referral indicating need for one-on-one. A good example of this would be barriers in a group learning environment or a need for one-on-one insulin training. A group is defined by Medicare as 2 to 20 individuals. Since 2009, we have seen significant changes in reimbursements and a focus on value-based payments and quality reporting. While we can argue about the politics and programs, it is becoming increasingly important to measure patient outcomes. Proactive processes that decrease hospital utilizations and improve health metrics should be included in provider workflows. Diabetes self-management education has been proven to lower individual health costs through numerous studies. Cost analysis of diabetes self-management education has found a return on investment of $4.34 for every $1 spent. Hospitalization rates were 34% lower for patients who had at least one diabetes educational visit. A study by Duncan et al., published in 2009, documented that commercially insured members who use diabetes self-management education on average 5.7 less than members who did not participate in diabetes self-management. In October 2013, the Academy of Managed Care Pharmacy published the findings by Fitch, Pienson, and Iwasaki found that for people with diabetes, about 20% of Medicare costs were due to diabetes complications. The study found a $108 per month or $1,296 per year cost savings for members enrolled in a disease management program and a 0.07 member per year reduction in ED visits. This slide shows you some of those statistics. In order to receive reimbursement through Medicare, providers must be in-network and have an accredited program through the ADA or the AADE. This is one of the reasons why New West Physicians became accredited. We really wanted to make sure we were maximizing our reimbursement for our education that we were providing. So the steps to qualify for Medicare diabetes self-management reimbursement is you must be a Medicare provider, you must have diabetes self-management education program, and it must be accredited. Medicare MAC must be informed once program is accredited, and the accreditation period is 4 years. The next few slides talk about the accreditation process, and you can find more information on diabetes.org/pro or the AAD website. New program application checklist. So the next 3 slides talk about the things that are needed. The information that needs to be gathered is a comprehensive initial and post-program data. So they're looking for the average number of hours participants spend in the diabetes education program. They want it broken down by age, the type of diabetes, the average number of hours each educator spends in diabetes self-management education. Looking for statistics like the number of years the program has provided diabetes self-management education, number of participants seen in a year, and then other services that were provided at the site, for example, weight loss classes. They want to know the ethnic and racial groups that are served, if there's any special needs of the participants, if there's they also want to know the behavioral outcomes and other participant outcomes. And then they're going to ask for that by, you set a target and a goal, and you need to report that. The documentation that needs to be provided for new programs trying to be accredited is evidence of administrative support, so a letter from an administrator in your company. You'll need to provide the program coordinator's professional licenses, also their proof of continuing education if they're not a diabetes educator or a board-certified diabetes educator. Professional instructors, so the people who are helping to teach the program, they need to have verification of current credentials. They need to have verification of licenses and verification of continuing education. Paraprofessional instructors need to also provide proof of training, certificates if applicable. Also for accreditation, you'll need to submit paper audit items. They will want to see that there is documentation of an advisory group. This advisory group must meet every 12 months. The program coordinator's job description or resume. A formal continuous quality improvement plan. An assigned section of the written curriculum. And then a de-identified patient chart showing all of the steps that the diabetes self-management education cycle has been completed. This link is a great link for you to find templates and forms, examples of previously used items for accreditation. Very helpful. The next two slides, I think, are important for you to pay attention to so that you would know who can bill for diabetes self-management education. Make sure that you're aware of who cannot bill for diabetes self-management education as well. For provider groups with more than one location, the ADA's accreditation process allows for more than one site to be covered by the same program coordinator. The accreditation application will walk you through this process if it applies to you. Hospitals can add multi-site sites at other locations, but the multi-site has to do their own billing. Always check with your hospital compliance officer prior to adding a site and contact the ADA representative with any questions. A little more information about that. The ADA offers information at www.diabetes.org/ERP and has prepared numerous materials to help with your patient management program and quality improvement process. In my own experience, the education recognition team at the American Diabetes Association was really helpful, offering phone conferences and networking to answer questions and allow you to spend some time with other programs that were accredited or in the process of being accredited. Their website can help you sign up for those conferences as well. More information at erp@diabetes.org. So thank you for taking time to educate yourself on the Diabetes Self-Management Program. We're happy that our program is accredited, and we hope you found the information useful.